with to join Simon now for some questions?
Yeah, I might just walk down here a little bit because the microphone won't work. It's trying to... So first of all, we can take a few minutes just to take questions for Andy. Does anyone have any burning questions?
Perfect. That's why I like to speak about 30 minutes after lunch. It's perfect.
Thank you, both of you, Marilyn DeLuca, New York University. Andrew, I was particularly taken by your 12 points, and as a clinician and working beside them, I think often about what the patient's desired outcome is and what their choice is, and I think oftentimes we forget as we educate that we don't own the illness or don't own the birthing experience, but it's the patient. I'm just interested in your comments about how CPD should fit into educating clinicians, healthcare professionals about informing the patient about their choices and their approaches to patient management.
Yeah, you know, it's an interesting question. When you look at, and a lot of that is cultural. When you think about that issue, when I look at the colon cancer community, which is what I know the best, when you go to Europe, where there's the largest incidence of colon cancer in the world, there's a very different expectation for treatment outcomes than the United States. So the United States, when the FDA approves a new drug based on the fact that it will increase life for 1.5 months or progression-free survival for 3 months or something like that, here in the States, that's huge. That's huge. The drugs company stock goes up, and it's making all the newspapers that there's a new drug out for colon cancer. And that is big news because in some patients that drug may work for years. But in Europe, they don't have that expectation. You get the diagnosis, you get the medicine the government says you're going to get, you get the test the government says you're going to get, and there's very little expectation of getting more than what's provided to you. Whereas I think in the United States and other places, it's a fight to get all the medical care you can and the best medical care you can. And so it's very much cultural to begin with. And so it's a difficult question to answer because here in the U.S., for a doctor to say to a patient, listen, I could give you chemotherapy and I could give you all these other medicines and we could do surgery and we might extend your life for 6 months. That's a different conversation than may happen somewhere else where you say you have a decision to make. The best we could do is 6 months, and maybe you don't want it. That's not a conversation that generally happens here. So again, it's cultural. It's not an easy answer.
Andrew, thank you very much for your presentation. My name is Michelle. I'm the president of the National Academies of Practice. First of all, I was really struck how you started this work in 1988, long before kind of the tidal wave of patient engagement has been on our radar now.
98, but yes, still
Oh,
the same.
98, well,
Yeah.
still,
Same.
88, 98.
It was the same, yeah.
What I have really noticed, both professionally, and then I've been walking a journey with my brother for the last year who has cancer, and my husband, who is a business owner, has been his primary advocate. And he's like, people don't know how to dialogue. They don't know how to have conversations. So I was really struck by your point of the informed patient, that we need to have dialogue with them and not be afraid of it. What have you learned has worked well to help all clinicians, physicians, nurses, therapists, learn about how important it is to listen to the patient and have the skills to be able to be engaged in dialogue? Any thoughts on that?
I have a thought, but it's my thought. It's not based on, again, research or evidence. And my thought is that it's a generational thing. I think when you go back to the Marcus Welby days of the gray-haired 60-year-old doctor coming to the house and, everybody, ooh, the doctor's here. He's God. He's the person that's changed. So now we have informed patients, right? And we also have younger doctors, and I think younger healthcare providers, a new generation. And again, I'm not discriminating against anybody in the room that may be a little older than me. But I find, and I think a lot of people find, that the younger healthcare providers seem to recognize that better. And they recognize that patients are much more informed now, and they're much more, understanding that a patient's going to come in informed. And not every patient, again, that's generational too. A 70-year-old colon cancer patient is not coming in with lots of information from the internet unless they have a strong person like your husband to help them. Whereas a 25-year-old cancer patient's coming in knowing almost as much as the doctor about their disease, right? So, I could be totally off here, but I really think it's slowly getting there. As many things are slowly getting there as a new crop of healthcare providers come in. And I don't know the answer as to how to change it for everybody, but I think it's changing just naturally.
So I thank you for your presentation. It was very compelling. Susan started this meeting with the word global, the global forum, and I was struck by thinking about HIV/AIDS advocacy and patient advocacy in other settings, South Africa, India, and so forth, with cost of antiretrovirals was $10,000 per patient per year. And your bullet point that find a way to pay for it. That point kind of, and I'll just sort of bring it out, that at this table we talked about population health, and even in the definition of value, there's cost. And this is, I think, the sort of tension, and as a young clinician and as also an advocate and a former patient who almost died of cerebral malaria in India, I struggle with this. And so I'm just really curious on your guidance, because I think this is the sort of 21st century question of how do you balance patient rights, what you're talking about, and that is the right thing to do, with all the stuff going on in the budget and with all the realities of what all the health system leaders have to deal with on population health. So I'm just really curious. It's more for the group, but
I wish I had the answer.
No,
it's that is a subject of multiple conferences, multi-day conferences in and of itself, is how we're going to pay for all this, because we see as technology is getting better, so are the treatments, right? We see that in the cancer space and hepatitis C space. We see cures now. Very expensive cures, but we see cures. And so the question is, for this $80,000 hepatitis C treatment that we now know, or $100,000, whatever it costs, is a cure for the hepatitis C. It's a cure. My God, a virus has been cured, right? But how are we going to pay for it? But there's millions and millions and millions of people that have hepatitis C and the HIV. And you could go on and on and on through every disease, starting with diabetes all the way through cancer, and do the same health technology assessment on each therapy and do this cost-benefit analysis. And unfortunately, it's coming to the United States. And unfortunately, it's been around for a long time around the world. When you look at NICE, the governing body, one of the governing bodies in Europe that approves medicines or approves payment for medicines, they do a full-blown health technology assessment. What is the cost of this patient's life worth? And there's a great video you could watch. It's called The Value of the Price of Life. It's called The Price of Life. And it's a BBC documentary that goes behind the scenes of a NICE approval of Revlimid. And you actually see the cancer patient come to NICE and say, I have this cancer, I need this treatment, it's the only treatment out there. And then he participates with the whole panel of reviewing this, and at the end of the day, they said, this drug's too expensive. We're not going to pay for it because it doesn't give you a long enough life expectancy. It's the value of a year's life of a person. So what is that value? Well, in one country, it's different than the next country, but should it be that way, or should every patient have access to every therapy, no matter where they are in the world? And that's what we advocate at IAPA, the International Alliance of Patient Organizations. Our main mission is universal quality health care in every country in the world. How do we get there? Well, we don't know. We've got a nice 3-year plan we've put together, and we are targeting countries like Africa and India and places where access is a major impediment. And it's very sad, because why should my uncle, who died of hepatitis C, couldn't get the drug in time, and he died from it, whereas somebody else didn't die from it. They got cured from it. What separated those two? What was different about them? It was all about access. So I wish I had the answer, and it's a growing problem, not a problem that's going away. And we hear the current administration talking about, hammering the healthcare system and in costs. And I don't want to get political by any means here down in Washington, but when you talk about negotiating with drug companies, bringing the prices down, and cutting $16 billion from the NIH and things of that nature, proving the value of treatments for patients is becoming much more important and much more of a hot topic and a discussed topic every day.
So I think we've got 5 minutes. So if we can just go Brenda, then Joanna, is that okay?
Thank you, and thank you, Andrew. Brenda Zeeler from representing the American Academy of Nurses. I appreciate you sharing your story. A lot of the words you used around doctors, physicians, clinicians, health professional providers, and I think about cancer care, which is really like chronic disease management, because cancer has become a chronic disease. It really requires a team approach. And probably the least amount of time is going to be spent with the provider decision maker and much more time spent with the other members of the team providing comfort, information, social work, nursing, pharmacy, therapist. And so I'm wondering if, thinking about your slides, thinking about maybe it's a team needs this CPD and not a health professional provider, but thinking more broadly, because that's who does provide care to patients with cancer.
Oh, if you ask the patients themselves who they go to for comfort, who they go to for information, they go to all of those people you named, not the main physician. They'll have their 15 minutes every month or two with the main oncologist or surgeon or physician. But the vast majority of services, like you say, the chemotherapy patients, they're sitting there with a nurse and a social worker for hours, developing a relationship, developing a rapport, getting valuable information from them. So I totally agree with you that it is a team approach and that CPE really should be given as a team approach. That's a good point. Here, I thought there'd be no questions.
So I'm an oncologist, and some of the best advice we've had in sort of framing training for physicians has come from some of my cancer patients. But I've observed over the years that many are very uncomfortable in settings where they could be extremely valuable. So they won't come to a big meeting. They'll give opinions on the side. Or if we're starting to talk about business cases, they would not be comfortable coming into that conversation. However, I think it is critical that they're there in the design, even of a business case, to put some meaning into how do we prioritize these values. So my question to you is, where are we going to find these individuals who can toggle that, who, is that something we should be developing in our patient populations, in a sense, the education to be able to have those conversations that set standards for the future?
Yeah, that's a great question. So patients are very intimidated, as you say, about getting into the academics of policy issues and discussions and things of that nature. They feel, I think generally they feel like I do, the dumbest person in the room, like I do today, right? That you guys are at such a high level that what could little old me possibly, contribute to the conversation? So you're right, they won't participate. And that's something that I think has been true in many other healthcare settings. Policymakers, governing bodies have not traditionally asked for the patient viewpoints, right? WHO, FDA, but that is changing. So patient groups, patient advocacy organizations now have a very strong voice in policy. We are invited all the time to the WHO, the WHA, the FDA, CMS, and it really is a part-time job going to meet with regulators and policymakers to present the patient voice and fight for coverage where we have to fight for coverage, fight for testing approval, fight for device approval, drug approval, whatever it is that the patient voice is needed, wherever it is needed, we're invited. And that's different than it was in the AIDS community years ago. And thankfully, the AIDS community did a fantastic job, along with the breast cancer community, in getting the patient voice to be heard. Think about the ladies in the breast cancer world who chained themselves to the fence at Genentech until they could get their Herceptin, was it? Herceptin? So, those advocates changed the landscape and made the patient voice heard. Where it's not being heard is CP, continuing professional development. I've never been asked to speak at anything like this before. Now, I speak at CE things to educate physicians about colon cancer, or I'll do a lot of speaking on biologics and biosimilar policy that's coming, so we educate pharmacists, but that's different. We're talking about including the patient advocates in the planning meetings for CE, bringing the patient advocates who represent the patients. They'll come, we'll come. We come to these things all the time. We come to policy sessions. So invite the patient advocates to the CE planning and get the patient perspectives through them. They'll come.
One last question.
Laura Magaña from the Association of Schools and Programs of Public Health. Thank you for your perspectives in terms of the patients. But I was just wondering, how do you integrate here prevention and health promotion? Because we don't want all to be patients at the end of our lives. We want to be really healthy citizens. So beyond the care, what do you see as a patient talking about integrating really prevention and health promotion? Thank you for your talk.
Well, I think that colon cancer is a perfect example to answer that. Go back 20 years, and no doctor in the country, probably in the world, was recommending colon cancer screening. Nobody had heard of colon cancer before Katie Couric, right? Nobody was getting colonoscopies 20 years ago. Doctors were not recommending screening, right? Now, fast forward, healthcare providers have been fully educated through continuing education programs on what the screening guidelines are for colon cancer, because it's the most preventable major cancer through screening. Think about that. You go for your mammogram, you're trying to detect cancer. A guy goes for his prostate exam, you're trying to detect cancer. You go for colonoscopy, you have an opportunity to prevent the cancer because the colonoscopy can remove the polyp. It never turns into cancer. So it's the most preventable major cancer through screening, prevention. It's a great example because 20 years ago, 50,000 Americans were dying every year, 1.2 million people in the world being diagnosed with colon cancer because doctors were not having that conversation with the patients, right? Now they are. Now the quality measures are in place. HARQ has the quality measures in place. Doctors are judged by the number of colon cancer screenings they recommend for their patients. Doctors stay on top of their patients from a liability perspective. Many factors went in to doctors changing their behavior, but primarily it was CE. It was continuing professional development. Sorry, I'm getting used to that. It was CPD that has changed the landscape and saved literally tens of thousands of lives in the last 10, 15 years. And so there's a great opportunity there for the prevention message for healthcare providers to continue that message. And now that if ACA survives, or at least the preventative measures of the Affordable Care Act survive, we all know that all of those services are covered. So there's really no obstacle as to why people aren't getting these preventative measures as long as the healthcare providers are recommending them. So I hope that gives you a little answer, that there's hope. Yep.
So I think that just about draws us to a close, Andy, but that was that's an excellent Q&A, very inspirational. Thank you very much.
Thank you.
Really
Thank you.